So we'll start at 8:03, inshallah. I see Hannah is online now. So are we live on Facebook as well, Ahmed?
Oh, yes, we are.
Yes. So 2 more minutes to go. One more minute. Dear doctors, dear pharmacists, and all healthcare professionals, good evening or morning, wherever you are. Today is the 27th IVPN-AR addressing multiple myeloma, which is the last series of part 3 of Value of Innovation in Cancer Treatment for 2021. Multiple myeloma used to be considered extremely deadly, and today, because of the access to innovative therapy, that many people live with it as little more than a chronic disease. One reason it remains deadly is because many patients cannot get optimal and innovative therapy, and mainly probably due to failure to access of therapy. This event is thankfully supported by Janssen as an educational grant. Janssen has been truly an amazing partner and supporter to IVPN in year 2021 and hopefully for the years to come. They have always been pioneering in spreading pharmacotherapy education and knowledge transfer, especially to the pharmacists. Tonight, we are honored to host 3 distinguished regional and international speakers. Our first speaker will be Dr. Hana Abdul Karim from Saudi Arabia, followed by Dr. Islam Al-Konesi from the United Arab Emirates, and then last but not least, Dr. Karen Suez from the USA. Our speakers will cover very interesting topics, including multiple myeloma pharmacotherapy overview, innovative therapy, and pharmacoeconomic burdens of the disease. Special thanks to Dr. Fatima Ismail from Lebanon, who is our oncology listserv leader, for moderating this event. We are honored by the collaboration with the American Pharmacists Association, Saudi Society of Clinical Pharmacy, Eden's, King Saud University, Jordan Pharmacy Association, Lebanese Order of Pharmacists, and Marifa Management, particularly the great support of Anusha and Jessa in supporting this IVPN-AR. Special thanks to the organizing family, Rida and Maryam, and to Dr. Ahmed Al-Awaini, the chair of IVPN-AR, and to all IVPN leaders and ambassadors in making IVPN-AR a successful journey. I wish you a fruitful 2 hours event, and please don't forget to attend the last fun session, Kahoot, presented by Dr. Ahmed Abdel Daim at the end of this session. Now I leave the stage to Ahmed Al-Awaini for his updates on the CMEs and to introduce our amazing moderator, Fatima Ismail. Ahmed.
Thank you so much, dear Dr. Osama, for your kind introduction, and sincere welcome to our distinguished top-notch speakers and respected, passionate audience. Good day wherever you are. Thank you for joining us today for a new exciting station in IVPN-AR journey, the journey where we consistently strive to spread awareness on timely pharmacy topics and stimulate your desire to become the best version of yourself professionally, academically, and personally. Proudly, this IVPN-AR is accredited by, excuse me, oh yes. Okay, it's accredited by 1.5 CME hours by the American Council of Pharmacy Education for US licensed pharmacists, and 1.5 CME hours by Order of Pharmacists in Lebanon, and 0.5 hours by the Jordan Pharmacists Association. For those in Lebanon and Jordan, it will be reflected into your account within 3 to 6 weeks of this event. Whereas for US licensed pharmacists, you will see after each code an attendance code that will be prompted to you by Dr. Fatima Ismail, the moderator tonight. Each code is equivalent to 0.5 CPE hour. So please, for US licensed pharmacists, take note of those codes, after which by 1 to 2 weeks, you will receive the instruction by the email, and then 12 hours later, once you do those instructions, they will get reflected into your NABP profile. The IVPN-AR certificate will be shared with you by our team by 2 weeks from now, maximum in September 25th. And we always encourage you and welcome you to visit our IVPN-AR library, which is our legacy, where you can find all the previous recordings and the presentations as well for any topic that is of your interest. And now, thank you so much for, again, being here with us tonight. On behalf of my outstanding organizing family, Ahmad Rida, Mariam, always best mentored by Dr. Osama Tabbara, wishing you an insightful, enriching IVPNR, focusing on a very challenging cancer type, multiple myeloma, and all the innovative treatments that are emerging in this field. Now we will go to introduce our amazing moderator for tonight's IVPNR, Dr. Fatima Ismail. Dr. Fatima earned her bachelor degree in pharmacy at Beirut Arab University in Lebanon, 2009. For the past 12 years, she started her career in 2009 as an oncology hospital pharmacist at Rafiq Hariri University Hospital in Lebanon. Also, she was appointed as a graduate assistant and preceptor for professional pharmacy practice in the Faculty of Pharmacy at Beirut Arab University. In 2011, Dr. Ismail started her journey at the American University of Beirut Medical Center in the pharmacy department as senior attending clinical pharmacist in the oncology team. She is currently the pharmacy representative in the bone marrow transplant collaborative practice team and a member of the bone marrow transplant and hematology order set committee. She also served as the preceptor for the BMT elective rotation for the PGY1 pharmacy residency program at AUB Medical Center. Also, Dr. Fatima is assigned as a subject matter expert on Beacon module and has contributed to the validation and treatment of plans, treatment plans and medication build. She's an active member of many professional societies, including ASHP, the Order of Pharmacists in Lebanon, European Society for Bone and Marrow Transplant, and American Society for Bone and Marrow and Blood and Marrow Transplantation. Finally, proudly, Dr. Fatima was recently assigned as the leader of the IVPN Oncology Listserv and the chief editor for Oncolite IVPN Oncology newsletter. Without further ado, happily having you with us, Dr. Fatima, tonight. Wishing you a fruitful webinar. The floor and mic is yours.
Thank you, Ahmad. I want to thank Dr. Osama for this opportunity. Thank you, Dr. Ahmad, for your introduction. I want to thank all colleagues in the IVPN family for conducting this beneficial IVPNR for our attendees. Dear doctors and colleagues who are virtually connected, I would like to welcome you all for attending the 27th IVPNR under the title of Value of Innovation in Cancer Treatment series for multiple myeloma. I want to thank our speakers for accepting our invitation, and I am sure we will enjoy and learn from this beneficial, fruitful meeting discussion. With no further delay, I am honored to introduce our first speaker. Our first speaker is Dr. Hana Al-Abdel Karim. Dr. Hana is currently the Director of Drug Policy and Economic Center in National Guard of Health Affairs, Riyadh, KSA. She is the Vice President of the Saudi chapter of International Society for Pharmacoeconomics and Outcome Research. Prior to this, she worked as pharmacoeconomics, specializing mainly in conducting pharmacoeconomic evaluation of oncology hematology medications as a member of several P&T committees. Dr. Hana obtained her bachelor degree from King Saud University in KSA 2008. In 2012, she completed postgraduate diploma in business and law from University of Sheffield in United Kingdom. In 2014, she obtained her master's degree on health economics and decision modeling from the University of Sheffield in United Kingdom, in addition to training in health economic of the University of Manchester. In 2018, she joined the Health Economics and Outcome Research Certificate Program from the University of Washington, USA. Dr. Hana's main professional and research interests are health economics and outcome research, optimal healthcare resource allocation, informing decision-making with regard to drug use, and finding cost-central strategies. Dr. Hana will be discussing today the pharmacoeconomic burden in multiple myeloma management. Dr. Hana, we are happy to have you. Please, the floor is yours.
Thank you, Dr. Fatma, for the nice introduction. Thanks for the IVPN-AR team, Dr. Osama, Dr. Al-Awaini, and all the rest of the team for the kind invitation. Unfortunately, I have to turn off the video to make sure that I maintain the quality of the connection. So as Dr. Fatma said, I'm going to be talking about the multiple myeloma from different perspective, which is the economic perspective. I'm not sure if you can see my slides.
Yes, Dr.
Yes, we can.
Because I'm trying to scroll down, but I'm not sure if they're moving.
Just click anywhere on your screen, doctor, and then you can.
Yeah, okay. I think it's moving now. So primarily this evening, I have 3 key objectives. First, to discuss the economic burden of multiple myeloma, highlight the value of innovative treatments of multiple myeloma from economic point of view. Also, I will try to explore some of the different strategies and approaches to reduce the economic burden of multiple myeloma. So let's start with a few slides about the economic burden of oncology, hematology drugs in general, with special focus on multiple myeloma. This slide shows that the total global spending on oncology, hematology drugs, which, as you can see in this slide, makes around 28% of the total spending on drugs worldwide. And the total global spending on oncology in particular exceeded 120 billion US dollar based on sales data in 2020, as more than 60 new cancer treatment for more than 90 indications entered the market over the past 5 years. So you can see that also the report estimates that global costs are expected to, for oncology only, could reach 230 billion in 2030. So as you can see, these are really big numbers without even accounting for non-drug costs. Speaking of multiple myeloma in particular, the market size stood at 19.5 billion US dollar in 2018, with expectations that it could reach 31 billion dollars in 2026, with growth of around 6% during this forecast period. So I tried to look into the literature to find some of the studies that could estimate the total cost or economic burden of care for multiple myeloma patients. However, doesn't seem that there are a lot of studies. I found only few good quality studies from the US. This is one of the best papers I found, which documents recent trends in the economic and resource use burden in patients with newly diagnosed patients with multiple myeloma. The good thing about this study that it was done following the approval of some of the newer agents. So this study found that the total average follow-up cost for all cause for patients who are newly diagnosed with multiple myeloma that could reach 288,000 per year per patient. And if we look at disease-related cost for all lines of therapy, it accounts for 253,000 US dollar per patient, which represents around 88% of the total. 30% of the disease-related cost is the pharmacy or drug cost. Hospital and inpatient cost represents around 30%. The remaining is 25% for inpatient visits, which was also, if you look at the study, is driven by provider-administered drugs. So what this study is showing us is that mainly the cost of multiple myeloma is driven by pharmacy and hospitalization costs. Further analysis in the same study showed that the drug-related cost per patient monthly was on average around 14,000 US dollar per patient per month, and this is a high number compared to other disease areas. They also tried to calculate the monthly cost per patient based on a line of therapy. So if you can see here that the costs for patients who have one line of therapy is around 16,000 US dollar. It increased to 20,000 US dollar in the second line, 17,000 in the third line, and around 20,000 for patients who are on in the fourth line of therapy or after the fourth relapse. Another interesting study, or it was a systematic review, honestly, that was published between 2005 and 2018. It reported all the studies that reported economic burden of multiple myeloma, whether it is direct cost, indirect productivity, or any other resource used in newly diagnosed adults with multiple myeloma. This study found that in the US, the total direct cost of a newly diagnosed patients is around between 11 and 16,000 per patient per month, which is comparable to the number reported in the previous study. They found that also the cost drivers in those patients are the inpatient admission and ADRs that were reported to have a high percent of the cost. One of the interesting conclusions of this study is that they found that the addition of lenalidomide to treatment regimen can result in a substantial cost increase of up to 70%. This systematic review, one study only reported data on productivity, and it was found that the effect of multiple myeloma on productivity of the patient can range between 14,400 to up to 18,329 per patient per year. So this shows that the significant burden of multiple myeloma on the patient and on society. So this makes us think what drives the spending on multiple myeloma. And this is not only based on studies, it's based on my experience in hospital setting and what we see, what we are suffering from in the management of multiple myeloma. One of the critical market drivers in the increase of the cost of multiple myeloma is the increase in the prevalence globally. Despite the fact that multiple myeloma is considered a rare disease, it still affects a significant number of cancer cases worldwide. Also, the aging population. We know that most of the countries around the world have now aging population, and it is estimated that with the aging population from 2010 to 2030, there will be around 57% increase in the number of patients who will be living with myeloma. Also, there is a general increase in the awareness regarding this disease and its symptoms, which likely led to increase in numbers of diagnosed patients, which eventually will lead to higher cost to the system. There is also the cost of complications. As you know, this disease is associated with a variety of complications, including but not limited to anemia, neutropenia, thrombocytopenia, bone loss, and fracture, kidney issues, and several other difficult to manage and expensive to manage complications. Another also very important point is that due to the launch of innovative treatments during the last 10 to 15 years, patients now are living longer. So patients who were diagnosed in let's say 2010 had better survival rates compared to those who were diagnosed before this year. Also, we need to think that so this slide shows all the treatment regimens. I'm not going to talk about them because I'm sure that they will be covered in the next two presentations by my colleagues. However, what I wanted to show here is that increased growth in R&D activity since 2003, since as you can see here, several therapies received approval from regulatory authorities for the treatment of patients with multiple myeloma. And this dramatic increase, dramatic advances, I mean, in the treatment of multiple myeloma over the last 2 decades have resulted in significant improvement in overall survival, with 5% survival jumping to 50% or maybe 60% in patients who are younger than 70. So for patients who are for example, if patients are refractory to one treatment, then they will receive, and as you know, in multiple myeloma, patients will keep on relapsing. Say if they will take the treatment for 5 to 8 years on average, then they will relapse and they will take another treatment. Probably most of the times, the other treatment option is a doublet, a triplet of these expensive drugs. You can imagine the long-term financial toxicity of these combination. So a study that shows that comparing the percent of patients who have multiple myeloma who use novel treatments in 2000, only less than 9% of the patients used novel treatments. However, in 2014, more than 60% of the patients receive novel treatments. The study showed also that that patients with multiple myeloma are have the highest number or the highest percent of patients taking targeted oral anti-cancer medications. Also, another study that included 2,500 elderly patients in the US with patients with advanced multiple myeloma between 2000 and 2009, they compared patients who are on novel agent-based treatment, for example, thalidomide, lenalidomide, and bortezomib, or patients who are receiving chemotherapy. And it was found that the cost of patients who are receiving novel agents is around 2 to 3 times the cost of those who are getting chemotherapy. It was also found that the percent of drugs from the overall care was 31% in patients who are receiving novel agents, only 19% on those who are on chemotherapy. So with all these new innovative drugs that will definitely improve survival, quality of life. However, they come also with a substantial financial burden on our system, on our patients, and on the society as well. So we need to confront here the stark reality that cancer care, and especially multiple myeloma care, is no longer affordable. What we need to understand here is, regardless of the activity in R&D, if the medication is there in the market, the company is promoting the drug and you cannot afford it, then you cannot say that this is effective treatment. The effective treatment is the one that you can afford to give to your patients. So let's talk about several strategies that can help us in driving down the treatment cost of multiple myeloma. Although most of the suggested solutions and strategies are not unique to multiple myeloma. They can be used also with other cancer treatments. The most important strategy, in my opinion, to reduce the burden of multiple myeloma is to focus on developing national guidelines that takes cost into consideration. So instead of having a guidelines that simply lists all the various treatment options as being reasonable alternatives, leaving the decision to each healthcare provider, it's better to have a guidelines that specifically state a cost-oriented guidelines that specifically state the cost of each treatment option, showing the nearly equivalent alternatives in terms of efficacy and safety, showing the difference in cost. So the most important message here is not going to the lowest price option, rather than to go to the best available option. However, if there is another treatment option that is near equivalent in terms of efficacy, but with lower price, then you have to go to the lowest price option. So we need also to remember that cheaper is not always better. Cheaper is not always cost effective, because if you go to the least costly, least effective option, you will end up with complications, and then the impact on the system will be greater. An example here of two treatment options. As most of you know, and as will, I'm sure that it will be discussed in the next presentation, in frontline treatment setting, usually patients are classified either to transplant eligible or transplant ineligible patients. For those who are not eligible for transplant, usually we give them triplet combination. Mainly lenalidomide-based regimen, which is a VRD. VRD is bortezomib, lenalidomide and dexamethasone regimen, which is usually given for about 9 months. Then after that, we give maintenance therapy with lenalidomide for indefinite duration. So using this particular regimen, you can guarantee for your patients 4-year survival rate of around 60 to 70%. Some physicians try to use newer triplet combinations such as DRD or KRD. So taking KRD in particular, which is carfilzomib, lenalidomide, dexamethasone regimen, several studies have shown that these two regimens, VRD and KRD, have similar response rates, similar BFS, and similar overall survival. However, you can see in the slide the difference in costs. VRD costs around $29,000 per year, while KRD regimen costs around $93,000. And these are based on the current prices in the Saudi market. So the recommendation here is whenever you have two regimens that are equivalent in efficacy, try to go to the one with lowest price. Another suggestion is to use the innovative payment models, or what we call risk sharing agreement, managed entry agreements, several names for these kind of agreements, and they're widely used now because of the trend and increase in prices of medications. So simply, managed entry agreements is an agreement between the manufacturer and the payer that allow earlier access for the medication, sometimes at lower price, sometimes at an agreement that allow sharing the risk between the two parties. Examples of these agreements that might fit treatment for multiple myeloma is expenditure cap. For example, we say to the company that we will be treating, we will be providing the cost of 20 patients. However, if we end up with 25, then the extra 5 will be paid by the company. We have also volume-based agreement where you put patients or number of vials on different tiers, and then you say, for example, in the first one I will be from 0 to 500 patients, for example, or maybe this is not a realistic number in multiple myeloma. Let's say from 0 to 20, I will be paying the tender costs. If we have more than 20, let's say 20 to 40 patients, then I will get 10% extra discount. If we exceed 50, then you will give me 15% discount. This is to reduce the risk of inflation and budget in case you are not certain of the expected volume. Another type is coverage with evidence development, and this is a good kind of agreement when you have a drug that have a great deal of uncertainty in terms of either efficacy or even safety profile. If you are not sure that your population will respond and achieve the same response rate in clinical trials. We have also outcome-based agreements, and they're widely used now, where, for example, if after 2 or 3 months patients did not respond, then we will not be paying for those patients to the company. I will try to give examples of these agreements worldwide, because most HTA agencies, health technology assessment agencies, and national health systems around the world recognize the burden of multiple myeloma and the skyrocketing prices of novel agents. So one of the agreements, for example, is the outcome-based agreement conducted by the NHS in the UK with the manufacturer of bortezomib, where the full cost of the drug is returned by the manufacturer for patients who have less than partial response. So if the patient, they collect the data, if, the number of patients who fail to reach partial response, the company will provide rebate to the payer. Another type is the free initial treatment. For example, we conducted this agreement with the manufacturer of daratumumab. The issue was the high cost in the first year. So the company provided free initial treatment for 2 cycles, which reduced the financial impact on the first year. Another example is the patient level treatment or expenditure cap. For example, the agreement with the manufacturer of lenalidomide in England, where they agreed on certain number of patients, and beyond this number, the manufacturer will be providing the treatment for those patients for free. Another strategy that is also good in multiple myeloma, and we tried to include it in our guidelines in National Guard, is the stopping rule. Although we don't have really a good data around this, but still we don't even have good data that shows that treating patients for more than 2 years means that if you stop the treatment, it doesn't mean that maybe the durability of the drug is not ensured. So what we need to do is either conducting the trials to measure the durability of the response after 2 years, or stopping the patients and watch them. So what we did, for example, for lenalidomide, we decided that patients who are on the drug for 2 years not progressing, we will be stopping the treatment, and most of our patients maintained the response after stopping the medication, which also highlight the importance of collecting real world data. Data is really needed here to understand the relative value of different treatment options, to understand the safety profile, to understand the efficacy in each patient subgroup, in each line of treatment. As I said, durability of response after stopping the treatment. And also we need to collect data on resource use. One of the also important successful strategies that we used is shifting to subcutaneous daratumumab from IV. The provided drug was the same at the same price. However, the indirect cost was reduced by 90% because in IV treatment, we used to keep the patient from 6 to 8 hours in the IV suite, which also not only costing
Doctor?
a lot, but also, yes. I'll wrap up in 1 minute. So I was saying that shifting to subcutaneous daratumumab can potentially reduce the indirect cost by 90%. Also, we need to focus on reducing the cost of overheads, cost of physician visits, hospital stays, unnecessary lab testing and imaging. Another successful strategy is the use of generic and biosimilars. And I'm here using the current market price in Saudi Arabia. So you can see 2 years ago, the cost of bortezomib was around $1,400 per vial. Now it's only $188. Similarly, lenalidomide costs around $445 per vial, which fell to $55 per vial. So I was trying just to demonstrate the huge economic burden of this disease on the system, society, payers, and patients, which is driven mainly by high costs of innovative treatment options. And we need to focus on trying different proposed strategies to improve the efficiency of the system and optimize the resource allocation and to reduce the economic burden of multiple myeloma. Thank you very much.
Thank you, Dr. Hanan, for your comprehensive presentation. Actually, we have, okay, first we're gonna go, please find the attendance code. Okay, so we'll go with the Q&A questions. We have actually a nice question here by Sarah Zain. She's asking, in case of shifting from IV to sub-Q daratumumab, will this affect the efficacy of the drug?
No, actually, this dosage form proved non-inferiority, and it is provided by the same manufacturer. However, it's honestly, in practice, usually companies provide the improved formulation only upon the time of expiration of patency. But with this drug, it seems that the company is bringing a better formulation 2 years after the approval of the IV, which is great for our patients, for our system, providing more access to other patients to use the facility.
Great. We have another question by Dr. Samar. She's asking, how effective are biosimilars and generics? Any studies about that?
Well, biosimilars are usually approved based on equivalency studies and totality of evidence. Mainly regulatory agencies are considering these drugs equivalent to the original drugs. Case is a little bit different with generics because these are concerning the small molecules, not biological drugs. But if they're good enough for regulatory agencies, then it should be good enough for us.
Yeah. Actually, I have a question. In one of your slides discussing about the economic burden in US. In one of the studies, it said that 20% the cost were the inpatients and ADRs. So did they mention what types of ADRs, whether immuno-related or hematological side effects?
Well, that was a systematic review, so they did not provide specific details about each study. I can provide the reference and it's in the slide. However, it highlights the role of, I would say, pharmacists here, because we are in a unique position in the system that allows us to pick those mistakes and to prevent catastrophic ADRs that are not only bad to the patients, but also to the budget.
Okay. I think we have a question from Shuresh, I think. How do you evaluate treatment outcome with branded versus generic? And any controlling factors or parameters you look at?
Well, honestly, at hospital level, we don't. We just, if the generic drug meets the criteria, we do have, for example, in our sector, we have a scoring system for generics. If the drug gets a certain score, then we can shift for this drug. However, we have a good reporting and pharmacovigilance system after the launch of the new drug. So if physicians noticed difference in efficacy or unexpected safety issue, then they report it, and we report it to Saudi FDA, who investigate the issue, do a bioequivalency study, and then get back to us. So if there is an issue, we will definitely stop the drug, and they will generate a recall at national level.
Great. I have also one question. In one of the slides, you said the stopping rule is stopping the maintenance treatment after 2 years. So this is based on what of stopping 2 years rather than more than that?
It's not based on anything, to be honest. We don't have data that says that the drug is working beyond 2 years, but we don't also have data that says that it's not working. So the budget impact is huge. Other country used this strategy before. We read about it, and we trust the NICE in the UK. After 2 or 3 years from adapting this strategy in NICE, we felt that maybe if there is an issue with this strategy, then they would have stopped it, and we adapted this strategy. I can't say that doctors are complied with this, but we are recommending stopping after 2 years.
Great. Thank you so much, Dr. Hannah, for your comprehensive presentation and for answering our questions. Thank you so much.
Most welcome. Thank you very much.
Thank you. Now we'll be having the slide for the ACPE information for this session. The attendance code is JPMG. This is to be used by the US pharmacists to claim their CE hours. The claiming instructions will be shared via email within 1 week. So now we will be moving to our second presentation with our second speaker, Dr. Islam Al-Kunaisi. Dr. Islam is an international speaker. He is a member of the British Oncology Pharmacy Association Executive Committee, and he is the director of the United Kingdom Clinical Pharmacy Association. Dr. Islam is currently overseeing the launch of the pharmacy bone marrow transplant service in Abu Dhabi at Sheikh Shakhabout Medical City in partnership with Mayo Clinic. Dr. Islam has always championed clinical leadership in pharmacy practice. And as a member of the Center for Pharmacy Postgraduate Education Hospital Pharmacy Advisory Panel, he has helped develop a leadership program for hospital pharmacists. Dr. Islam will be discussing today the general overview of multiple myeloma pharmacotherapy. Thank you, Dr. Islam. We are so happy for having you. The floor is yours.
Thank you, Dr. Fatima, and I'd like to thank Dr. Osama and Ahmed and the entire IVPN-AR family for inviting me to speak today. So this is adapted from Ken Anderson from a few years ago, looking at the drugs that have been developed over the years for multiple myeloma. And as you could see, from 1958 to 2021, there have been a lot of developments from different classes. Now, in multiple myeloma, it is important to understand that there is always a debate on how to approach treatment choices, a debate on defining what standard risk is and what high risk is. Now, before we delve into this discussion, which I don't promise to be as exciting as watching Cristiano Ronaldo play for Manchester United tonight, I will briefly talk about what multiple myeloma is and what the key signs and symptoms are. So to begin, multiple myeloma is the second most common hematologic malignancy in adults and represents 10 to 20% of all hematological malignancies. The median age of diagnosis is 64 years, and the incidence increases with age, suggesting that in nations where there is an aging population, the incidence tends to be more prevalent. Now, myeloma is a cancer arising from plasma cells, a type of white blood cells, which is made in the bone marrow. As we say to our patients, the bone marrow is that spongy material found in the center of the larger bones in the body. And as we all know, the bone marrow is where all the blood cells are made. Plasma cells form part of our immune system. And normal plasma cells produce antibodies known as immunoglobulins, and they play a crucial role for fighting infection and supporting the immune system. But in myeloma, plasma cells become abnormal. They multiply in an uncontrolled manner and release only one type of an antibody known as paraproteins, which is not useful whatsoever. So it's through the measurement of this paraprotein that myeloma is diagnosed and monitored. Like many cancers, myeloma doesn't exist in a lump or a tumor. So most of the symptoms and complications related to myeloma are caused by the buildup of the abnormal plasma cells in the bone marrow and the presence of that paraprotein that I just mentioned in the blood and in the urine. So the wording or the terminology multiple comes from the fact that myeloma affects multiple places in the body where bone marrow is normally active. So in an adult, we have the bones of the spine, skull, pelvis, the rib cage, long bones of the arms and legs, and the areas around the shoulders and hips. Before I move on to the next slide, I'd just like to note that myeloma is a relapsing, remitting cancer. That means there are periods where the myeloma is causing symptoms or complications and needs to be treated, but also there are periods of remission or plateau where the myeloma doesn't cause any symptoms and doesn't require treatment. So we can broadly say that for the treatment of multiple myeloma, there are newer drugs, as I like to call them, chemotherapy, traditional chemotherapy agents, corticosteroids form the backbone of that management, and stem cell transplantation. The initial choice of therapy depends on the patient's health, age, and ability to undergo stem cell transplantation in the future, as well as the aggressiveness of the disease. Most patients will be treated with a 3-drug regimen that includes a proteasome inhibitor, an IMiD or an immunomodulatory agent, and a corticosteroid. One thing before I start discussing individual treatments is that there isn't a standard induction treatment for multiple myeloma management. Treatment choices are debatable, as I said earlier at the beginning of that presentation, and it is important that we tailor treatments to the frailty and comorbidity of the patient. But one key strategy is that combining agents with different mechanisms of action provides a synergistic effect, and that's because myeloma cells are dependent on the bone marrow microenvironment for growth and survival. So disrupting that microenvironment may be an effective strategy to control the disease. And targeting the myeloma cell itself with novel agents also target various supportive mechanisms within that bone marrow microenvironment. So including disrupting adhesion between myeloma cells and stromal cells, inhibiting angiogenesis, modulating the immune response, inhibiting osteoclast activity, and stimulating osteoblast activity. So because of the fact that different agents have different molecular targets, combining agents together with different mechanisms of action will have a synergistic effect and will play a key part in providing a deeper response in the management of the disease. So in the management of newly diagnosed multiple myeloma, as I said earlier, the key initial question is that whether the patient is eligible for an autologous stem cell transplantation. Stem cell transplantation can be done using one's own stem cells. So autologous comes from the fact that you're using your own stem cells. If you're using stem cells from a close relative or a matched unrelated donor, it's called allogeneic stem cell transplantation. In multiple myeloma, most transplants performed are of the autologous kind. So such transplants, they're not curative, but they do prolong life. And it is important also to note that organ dysfunction such as renal impairment don't normally form a barrier to transplantation. Age is the barrier, patient preference is definitely a barrier, and the presence or absence of a significant comorbidity, such as uncontrolled chronic disease like diabetes, often affects our decision-making in practice to go for transplantation. The following just represents some of the regimens, and by far this doesn't mean that those are the same. It just explains that there are a wide variety of regimens used in induction and consolidation and maintenance, particularly for autologous stem cell transplantations. To begin, I will talk to you over the next few slides on some of the classes in managing multiple myeloma, particularly beginning with bortezomib or proteasome inhibitors. So I lost my screen. Can you all see my screen, Ahmed? I have my screen back. All right, so proteasome inhibitors are breaks, or the proteasome in particular, the function of that proteasome in the body, it breaks down proteins in cells and is especially active in multiple myeloma cells since they have a lot of excess proteins being made, as I said earlier, the paraproteins. So inhibiting proteasomes block this action so that proteins build up and the cells die. And that's the basic principle of proteasome inhibitors. So bortezomib, carfilzomib, ixazomib, all form those parts of those classes. Usually bortezomib is given subcutaneously, carfilzomib is given intravenously, and ixazomib is an oral drug. Immunomodulatory agents, or IMiDs as we like to call them in practice. These drugs use the body's immune system to fight myeloma cells, and they include lenalidomide, thalidomide, and pomalidomide. And they all have the potential to cause severe birth defects and are absolutely contraindicated for pregnant women. When given with steroids, they also increase the chance of developing blood clots. Therefore, sometimes, depending on the risk of the patients, we give aspirin or even more low molecular weight heparins or DAWACs to manage any risk associated with blood clots. Now, talking over the next two slides on carfilzomib and ixazomib really briefly. So carfilzomib is a proteasome inhibitor, as I said earlier. There are multiple dose regimens that have been recommended from 27 mg per meter square to 56 mg per meter square. The most widely used and the most in trials have been in between those two parts, 36 mg per meter square. Having said that, the NICE guidelines in the UK have approved the higher dose of 56 mg per meter square with dexamethasone. We often have a dose cap of 2.2 meters square for body surface area. Carfilzomib is an infusion given twice a week, which can sometimes be inconvenient, and I'll discuss the practicalities issues in the next few slides. But this was one of the first trials that supported the use of carfilzomib, comparing carfilzomib dexamethasone with bortezomib dexamethasone in patients with relapsed refractory multiple myeloma. And as we could see from those Kaplan-Meier curves, that progression-free survival in the patient cohort of carfilzomib is much better than those in the bortezomib group. Also, overall survival is much better here. And the adverse events in using carfilzomib is particularly nasty when it comes to cardiac health. So if you're looking at hypertension, dyspnea, cardiac failure, ischemic heart diseases, and you're comparing both carfilzomib with bortezomib, carfilzomib is a very nasty drug with cardiac history. Peripheral neuropathy is more prevalent in bortezomib, as we can see here, but again, carfilzomib is often limited in usage because of this cardiac side effect profile. Practicalities is the inconvenience of twice-weekly dosing, tolerability in non-trial population, because those toxicities were shown in a unique, probably relatively healthy trial population. Questions around continuing or stopping maintenance always remain a debate amongst a lot of clinicians worldwide, and the excessive monitoring for cardiac health tends to be a challenge in practice. Moving on to ixazomib, the other proteasome inhibitor given orally. Again, this is the only oral drug given in the proteasome inhibitor setting. One of the first trials that looked at it compared ixazomib, lenalidomide, dexamethasone with lenalidomide, dexamethasone in the refractory relapsed multiple myeloma, so later settings, not the earlier settings. You could see that there is a significant 35% improvement in progression-free survival with ixazomib in comparison to lenalidomide dexamethasone. This is a forest plot that shows that ixazomib extends that progression-free survival benefit across a broad group of patients. If you could see, the benefit tends to be in favor in the left side of that forest plot in favor of ixazomib versus lenalidomide dexamethasone alone. And again, ixazomib also shows some favorable benefits in patients with high-risk cytogenetics. When we continue treatment with ixazomib, we tend to get a continued deepened response. So if you're looking at the horizontal at the horizontal line of this graph, you could see that as time progresses, you get more better and deepened response with ixazomib usage. Generally well tolerated, so in terms of safety, there isn't much of an issue, although we tend to get some confusion with lenalidomide toxicity that I'll discuss now. So one of the issues around ixazomib is the fact that it's given orally, and it should be given on an empty stomach 1 hour before or at least 2 hours after food. Dexamethasone is normally given in the morning with food. So what we ask our patients to do is that they take dexamethasone in the morning at 8 a.m. with breakfast, followed 2 hours later with the dose of ixazomib. And then at dinner time, you have your lenalidomide dose. The confusion of toxicity is a challenge in practice, and the SPC has summarized some guidance around differentiating between thrombocytopenia, neutropenia, and rash between Ninlaro or ixazomib and lenalidomide, as we could see here. So the general overall strategy in managing that side effect is to withhold lenalidomide and see which, if you see an improvement in practice or not. Not to forget that we have to monitor renal function and hepatic function with ixazomib as well. So that was ixazomib in the relapsed refractory setting. Now, also in the maintenance following autologous stem cell transplantation, ixazomib had been providing some outstanding, fabulous progression-free survival benefits, as shown in the MM3 trial in comparison to placebo. So one of the questions in practice is that how could we employ using ixazomib instead of a parenteral proteasome inhibitor as part of a maintenance therapy? One is you would use ixazomib in patients who are unable to tolerate limb maintenance and are in standard risk. In patients with high-risk disease who are unable to come in for weekly dosing of bortezomib or carfilzomib, you would always opt for an ixazomib oral treatment, or those with a high-risk disease who wish to consider less frequent visits to clinic after a period of VRD. Velcade is bortezomib. R stands for lenalidomide. Sorry, I should have clarified this area. So VRD or KRD maintenance. I will whiz through venetoclax because the data is still immature and it isn't in much use in multiple myeloma as much as it is in other hematological malignancies. But it's interesting to see that the venetoclax, as we all know, is a small molecule which selectively binds and inhibits the anti-apoptotic protein B-cell lymphoma 2. So if you're inhibiting the anti-apoptotic protein, then you're restoring apoptosis and therefore killing the cancer cell, if that makes sense. Results have been showing particular favor in favor for high-risk cytogenetics, as we see in the Bellini study here, that venetoclax is much better in comparison to pomalidomide when combined with bortezomib dexamethasone in managing high-risk cytogenetics in multiple myeloma. Key messages here to leave you with is that venetoclax is still immature, not in use. Tumor lysis syndrome isn't much of a problem when it comes to multiple myeloma in comparison to other malignancies. And I will move on to the first of the two agents that I've discussed today on anti-CD38 monoclonal antibodies. So CD38 is highly expressed on myeloma cells. Daratumumab is a human IgG1 monoclonal antibody that binds those CD38 expressing cells, resulting in cell death through direct and indirect mechanisms. And I'm not going to talk too much about the mechanism of action here, but one of the key studies nowadays is that is the Griffin study, because daratumumab is now being used in practice, particularly in the private setting when we don't have a lot of limitations in the regulatory parts or the money parts. In the upfront management of transplant patients, it's used also in the maintenance side, and it's used in relapsed and refractory multiple myeloma. So across all settings, daratumumab is being used. The Griffin study shows and compares dara-RVD with RVD. So daratumumab, lenalidomide, Velcade, i.e. bortezomib dexamethasone versus the same block but without daratumumab. And what we saw was that the response rates and depths were greater for DVRD at all time points. And if we're looking at the toxicity, they were very, very similar. So nothing leaning towards the using RVD or lenalidomide, Velcade, dexamethasone without adding the daratumumab to it. So in the upfront Griffin study, daratumumab is now being used in managing patients at the upfront setting that are transplant eligible. Now, for the relapsed refractory multiple myeloma, there were a couple of trials, Cyrus and Gen 501, that upon which daratumumab was approved in the management of relapsed refractory settings. Again, overall response was consistent in subgroups, including age, number of prior lines of therapy, refractory status, or renal function. This is a waterfall plot. Amazing deep responses shown for daratumumab, and the efficacy is shown here across the board, whether you're talking about median progression-free survivors and responders. The top line Kaplan-Meier curve here is the one representing daratumumab usage. Side effects wise, there is a significant issue with fatigue, nausea, anemia, thrombocytopenia. I'll talk about daratumumab toxicity with the respiratory function, but overall, only 4.1% of patients discontinued treatment due to adverse events. And let me tell you this, when we're looking at clinical trials for patients, we tend to focus on the efficacy and toxicity, but for toxicity in particular, we're focusing on grade 3, 4, and more importantly, how many patients discontinued treatment because of a toxicity. So the rate of discontinuation here is very low, and it is in line with clinical practice. So Daratumumab practicalities is that upper respiratory symptoms are most common. Dry, cough, wheeze, COPD and asthma tend to be a challenge. We do give our patients Montelukast to help reduce these events. And one of the things that you probably are aware of is that now we could give it subcutaneously, but whilst it was a blessing for a lot of patients, those with blood thinners that have a lot of bruises tend to favor IV. So it's not one pot fits all sizes. It's more around what fits and fits the patient needs. Again, this is the Maya study that looked at daratumumab in the transplant ineligible patients. So we looked at daratumumab, lenalidomide, dexamethasone versus len-dex, and the results are absolutely outstanding with overall survival, progression-free survival, and safety tolerability of the drug. These are the list of current drugs, current trials and outcomes in the relapsed and refractory settings. So to sum daratumumab use, it's one of the gold standard ones in the management of multiple myeloma nowadays at the upfront eligible transplant patients, those that are not eligible, and also in the relapsed refractory setting. Isatuximab is another CD38 inhibitor and works in a similar way to daratumumab. Again, in comparison with carfilzomib, isatuximab and carfilzomib alone, I mean, you could see that dexamethasone is always featuring. Isatuximab arm is showing a favorable response in the IKEMA trial. And then when combined with pomalidomide, again, isatuximab is showing a lot of favor here. The question is, when would we favor isatuximab versus daratumumab? The answer is not clear. There isn't data to support the isatuximab will be working when a patient is refractory to daratumumab or vice versa. Just to note that, they both have similar mechanisms of action. Darac has the ability to be given subcutaneously, but if you're comparing the IV part, we have less infusion problems with isatuximab than daratumumab. One of the most exciting new treatments in multiple myeloma nowadays is belantamab. So moving away from the anti-CD38 world, we're talking about BCMA strategy here. So BCMA is technically overly expressed on multiple myeloma cells, and those are associated with a lot of maturation and supporting the cancer cell itself. So belantamab mafodotin is an antibody conjugate of a monoclonal antibody based on BCMA strategy, where it does bind to the BCMA receptor and it is then internalized to kill the cancer cell. One of the major issues associated with it is keratopathy. Eye toxicity is a major problem with belantamab. We saw a lot of deeper responses, longer responses, probably over a year for using it in later lines of settings. But keratopathy is a big, massive problem in practice. Almost 9 out of 10 or 10 out of 10 your patients will get an eye or an ocular toxicity. So excessive monitoring, planning with an ophthalmologist from the beginning could be one strategy to reduce those problems of ocular toxicity of belantamab, but also dosing every 3 weeks could also accumulate the cornea toxicity within the cornea. Belantamab has a half-life around 14 days, so extending the interval of the treatment schedule could be another strategy to allow the cornea to recover. So when is it in the treatment course you should be recommending belantamab? Later in the lines of treatments, you need to be monitoring for eye problems. So at least 4 prior therapies, including anti-CD38, proteasome inhibitor, and an IMiD. That's the best time you start seeing a belantamab drug, and of course, your patients without an eye toxicity. Selinexor is another fabulous agent. It's an exportin inhibitor. And what happens is, in the myeloma cell, you have an exportin that delivers or takes the tumor suppressor proteins out of the nucleus to the cytoplasm. So if you keep the tumor suppressor proteins inside the nucleus with selinexor, then that ends up with the tumor cell death. Selinexor is a brand new agent, as I like to call it, and it has a lot of GI toxicity that could be sometimes nasty. But this is the first study that was published around 2 years ago, or looking at selinexor dex for triple class refractory myeloma, and it does show a fantastic good response. And today, you know, the most recent is that the Boston trial, the early and sustained progression-free survival benefit that we see in combination if we're using selinexor with bortezomib dex in comparison to bortezomib, you know, bex, you could see like a 13.9 versus 9.4 months difference in the selinexor arm. Melphalan flofenamide is another drug, brand new, one of its class. I'm not going to bore you with the mechanism of action, but it's an alkylating agent. And again, in the pivotal phase 2 Horizon study, the activity of melphalan is showing some fabulous results with the swimmer's plot here showing some really promising outcomes and overall responses and progression-free survival as well. I'm not going to talk too much about the data because I'm more interested into how we could integrate that melphalan in the management of our patients, the melphalan alkylating agent. And again, this is something that we should be using later down the therapy of managing multiple myeloma, and not earlier based on treatment and trials. Now, I've been inspired by one of the consultants that I work with, and he showed us the slide of what they don't teach you at Harvard Business School. So what you wouldn't probably be finding in clinical trials or papers is the reality of practice of what you should be using, what you should be monitoring, and the practicalities around it. So probably here the question is what they don't teach you at the pharmacy school. So one of the question is, out of all those regimens and this mess of many new drugs, what is the optimal first line and maintenance therapy for a transplant eligible patient with newly diagnosed average risk multiple myeloma? So the answer is very simple. For standard risk, RVD is always used. For patients who cannot tolerate len maintenance, alternative considerations include ixazomib, as I said earlier, because it did show a fantastic progression-free survival benefit. Combinations with carfilzomib or daratumumab in the Forte and the Griffin trials suggest that standard risk gain and benefit from combinations, but you still have a lot to do in terms of proving that progression-free survival benefit. Other question is, what is the optimal first-line maintenance therapy for our elderly patient cohort? We would be using MPs or MPs plus a novel agent. Again, RVD tends to feature as a standard usage across the board. And the optimal first line for high-risk cytogenetics, a lot of debate around this, DARA RVD, KRD in the maintenance setting. And again, the Forte trial showed that there is a minimal residual disease negativity for patients in the carfilzomib maintenance setting. And finally, as a key take-home message, because I realized that I haven't mentioned CAR-T therapy yet. The novel agents and strategies that are most promising for patients with multiple myeloma from this point onward. You know, when CAR-T first came, everyone was so excited because they thought that they would, CAR-T with chimeric antigen receptor therapy would be giving promising results similar to lymphoma, to leukemia. And it does show some really good benefit in the management of patients with multiple myeloma. But the reality is, if you look at the curve in those treatments so far, and we had a licensing for a multiple myeloma setting of CAR-T, is that it's a standard straight curve going down, what you would normally see in every multiple myeloma setting. However, we have a lot to do in terms of optimizing the management of those treatments, particularly based on our experience in the lymphoma and the leukemia disease cohort. So we need to think about early on, the approaches that we use. If we use BCMA targeted therapy like belantamab, will this then affect the CAR-T therapy down the line? We need to be thinking about our approach at the beginning of treatment. And we need to look at the way we manage those patients' toxicity later on as well. There is a lot of potential for CAR-T. This is why I would definitely agree that CAR-T as an adjuvant therapy or CAR-T later on would form part of those novel and innovative strategies for the future. Now, one of the things that we need to be thinking of is minimal residual disease. There is a lot of debate whether MRD shows benefit as a marker for the management of multiple myeloma, but lots of trials are ongoing at the moment in terms of working this out. But I hope, I've managed to give you a little bit of an idea around those treatment pathways throughout the years, and I hope this now makes sense to you, that from 1958, when we had melphalan, oral melphalan, VAD, high-dose melphalan, and all the way where we had the proteasome inhibitors, the monoclonal antibodies, the IMiDs, the HDAC inhibitors are a bit questionable for the toxicity and efficacy, but they had been developed for the management of multiple myeloma. There is a lot more to do, and the pathway is amazing. I mean, the key strategy here is to look at the patient, look at the comorbidities. If your patient had history of a peripheral neuropathy, you'd probably avoid a regimen based on bortezomib. And if your patient had issues with a cardiac problem, you would avoid a carfilzomib regimen. And then if you had an ocular toxicity, you would avoid belantamab. GI toxicity, selinexor is not your go-to. And I see multiple myeloma in a similar way that diabetes is being managed. We see a lot of treatments, and all of those treatments have advantages and disadvantages. And it's very important to tailor those treatments to the patient pathway and in context of local and cost considerations as well. Thank you once again, and I'd like to welcome any questions.
Thank you so much, Dr. Islam, for your presentation. Actually, we have a couple of questions from our audience. First one is from Ali Najadi. He's asking, which among the medications for multiple myeloma has narrow therapeutic index, if any?
Pretty much a lot of those treatments have a narrow therapeutic index. If we're talking about venetoclax, although not in practice use, that's one to look out for. Daratumumab, I mean, if you're looking at the management and toxicities, it's not in the textbooks answer of vancomycin or digoxin, where you have to measure levels and ensure that your patients, it's more around monitoring in the right way, not over monitoring and not under monitoring. So if I was to pick something, I'll probably pick some of the newer agents and the novel ones. Carfilzomib, for example, is a good one to mention because playing around with the doses and ixazomib, for example, or at the beginning when I spoke about the proteasome inhibitors. They are all narrow in their own, in their own right, and they require monitoring. They require clinical review as well as a blood, a blood monitoring aspect as well. I don't know if this answers the question, but it's very hard to mimic a scenario of a phenytoin or a vancomycin or a digoxin in the current treatments available for multiple myeloma.
So another question from Noreen. As an oncology pharmacist, how can we provide support for ocular toxicity for belamaf?
So the belantamab.
Belantamab,
okay.
Yeah.
Yes, so basically, one thing is a proper review of the history of this patient's eye condition. Diabetes is a risk factor normally for ocular toxicity, so bearing that into consideration, taking that into consideration. And then if you're managing it because it developed, because you have a keratopathy or because you have a dry eye, then you provide either chloramphenicol. Steroid eye drops work very well. Mostly 9 out of 10 of those patients on belantamab, they end up on a steroid eye drop. Chloramphenicol has a massive big role as well, an antibiotic eye drop. So you would be looking at the toxicity itself and how to manage it with available treatment options. But before the toxicity develops, it's always important to develop that close plan of monitoring your patient and having a regular ophthalmology review being done, a regular risk assessment being done in predicting the severity of this complication, because it's definitely going to happen.
Thank you. We have another question from Jav Ghaddar. He's asking, in patients undergoing VRD protocol, should we suggest to give biphosphonate systematically to reduce the risk of hypercalcemia and its effect on bones and heart?
The effect of the bisphosphonates on the bones and the heart.
Yes.
I'm always in favor of bisphosphonates. I'm a massive big fan, and I think the only issue that stops me from or holds me back from in practice is the osteonecrosis of the jaw and nothing else. So yes, the answer is yes. I would support the risk on the heart and did you say the bones?
Yes.
Is very minimal in relation to the benefits gained if we're giving it to our patient.
Great. So we have another question from Suresh. She's asking, how do you look at quadruplet or triplet treatment in newly diagnosed multiple myeloma patients? I think
How I look at it personally, I would say I would go with DARA VRD, so quadruplet versus triplet, because DARA VRD, if that question is what I understood it correctly, I think the question here is, if we use quadruple, would that then later on down the line preclude or prevent those patients from receiving DARA, let's say down the line, or another agent down the line? I would say no. The question is always, what is the most important treatment for your patient at this point of time? Not later on what would happen. And that could be a 4-drug regimen, especially if you're using, if you're looking at high cytogenetics, you need to look at that very closely, or high-risk patients. Again, you give your patient the best shot, and the best shot at the moment is DARA VRD, the Griffin trial that I highlighted earlier. And this is how I look at it. I don't think, I mean, the problem is you often get restrictions in practice with local agreements, NICE, for example, in the UK, and approvals. But in the private setting, you would go with DARA VRD the whole time, every day, all night. And if you use it at the beginning, you can use it later. It doesn't matter.
Thank you so much, Dr. Islam. Thank you for your presentation, and thank you for answering our questions.
Thank you for inviting me, and thank you. Thanks.
Thank you. Thank you. Now, so you can see the ACP information. The attendance code for this session is HJHW for our US licensed pharmacist. Claiming instructions will be shared via email within 1 week. And now we'll be moving to our last speaker for this event, Dr. Karen Suez. Dr. Karen is a clinical assistant professor of the University of Illinois College of Pharmacy and has an extensive experience in management of patients with hematological malignancies undergoing chemotherapy or stem cell transplantation. In particular, Dr. Karen has a detailed knowledge of the management of multiple myeloma patients with now over 5 years of experience practicing within a collaborative PharmD MD multiple myeloma clinic. She is primarily involved in clinical research related to myeloma patients and autologous transplant at UIC, with a specific emphasis on improving outcomes through investigating of pharmacokinetics and pharmacodynamics interaction regarding chemotherapeutic agents during conditioning regimen. She is also an assistant professor in the College of Pharmacy, and she is involved with teaching and training pharmacists, pharmacy residents, students, and international pharmacists. Dr. Karen will be discussing today the innovative therapies in multiple myeloma, transforming patient care. Dr. Karen, we're so happy to have you. The floor is yours.
Thank you. Let me share my slides. Okay, are you able to see my slides here?
Yes.
Perfect.
Yes.
So first of all, I would like to thank Dr. Osama, Dr. Ahmed, Dr. Fatima for inviting me to speak at this on this platform. I was very excited to hear that this was happening virtually, and it's my pleasure to be talking to you all today. I guess on the topic of soccer from our last colleague who presented, I have to say my Saturday mornings tend to get I guess bombarded unintentionally, because I work day to day with physicians from Italy, England, and Ireland. And so Saturday mornings tend to get very busy on my phone, because I get many texts about soccer, and sometimes angry. And I will say, I know nothing about soccer. So this is a nice departure from my usual Saturday mornings to be talking to you today. So I will talk about innovative therapies in myeloma and how it's really transformed patient care. And as you can see, you've already heard how the treatment landscape in myeloma has been revolutionized just in the last 5 years or so. And I will say there will probably be some overlap from the previous discussion, but what I'll try to do is actually bring a lot of my day-to-day experience, both clinically and from a research perspective, and give you kind of insights on the intricacies of these therapies and how we approach them in our clinic. And I do want to just kind of elaborate a little bit about what I do, because it is very important when it comes to kind of managing these patients. About 5 years ago at our hospital, we decided to start a collaborative model that incorporates a physician and a pharmacist, both specialized in myeloma. And each patient who comes to our clinic is seen by both a pharmacist and a physician. And decisions on management, supportive care, prevention of side effects, monitoring, all this is done in a collaborative approach. And actually, we've been able to publish some of our findings when comparing it to a conventional type clinic where pharmacists are there on consult versus being proactively involved in the clinic. So we've been able to show that this model can improve outcomes on many levels. And so from that experience, I can bring to you kind of our day-to-day experience with some of these novel therapies, in my opinion, on kind of the movement in myeloma and where we are going. So, okay, let's see if it advances. Okay, there you go. So briefly, the objectives are to furthermore expound on what you just heard, to understand some of the efficacy toxicity balances of these novel drugs. So speaking to that narrow therapeutic index, although we don't have therapeutic drug monitoring with most of these drugs, it is extremely important to understand that for most of these drugs, the window between efficacy and toxicity is quite narrow. And that's why it's so hard to manage these patients and really come up with firm, robust plans on how to best continue therapy to both balance efficacy, but also minimize toxicity in these patients. And then I'll elaborate my role as a pharmacist and how others who are trained in this area as oncology pharmacists can contribute to how we manage these patients on a day-to-day basis. So I know you've learned a little bit about the pathology and the pathogenesis of myeloma, but I really wanted to show you this slide because I think it's important to understand. Right now in myeloma, it's a largely incurable disease. So less than 15% of patients are actually able to achieve what we call a functional cure. And the majority of other patients, they undergo and basically follow this spectrum, this what we call the disease trajectory in myeloma. And you can see here, it's really important to understand this. the most crucial time in the treatment of myeloma is that first phase, the first line treatment. This is when we have the best opportunity at achieving the deepest and the longest duration of remission. As patients relapse and as they go through multiple relapse stages, the duration of response to each of these treatments gets less and less. And whether you're an innovative novel treatment or not, despite that, when we see a lot of these drugs, even novel, being used in the relapse refractory setting, on a whole, in general, CR rates range about 30 to 40% for all of these drugs. So what we will see actually is that a lot of these therapies that are being used in the relapse refractory setting will eventually, because they are novel, because they are innovative, because they are very effective, will try to move to the upfront setting to try to achieve even better responses so that we don't have to have, you know, later stages of resistance. Because as you move towards the disease trajectory, you start getting resistant myeloma clones and you have increased drug resistance and less susceptibility even to these novel agents. So I want to highlight that because this is really the setting where all of these new therapies are coming in and trying to induce higher response rates and MRD negativity. So you've already seen another version of this, but I guess my point when I look at this type of timeline is we've really moved away from cytotoxic conventional chemotherapy. It used to be that we would treat myeloma with single agent corticosteroids. And now we're actually moving, now in 2021, we're even trying to come up with regimens that are mostly eventually steroid free, but also now we're introducing, as you heard Dr. Islam talk, there's multiple drugs with different mechanisms of action, non-overlapping toxicities. And it's really in an effort, as we better understand the biology and the molecular pathogenesis of this disease, we're better understanding how to target the more resistant myeloma clones and improve progression-free survival in these patients. And our hopes is that we can increase that less than 10 to 15% of patients who are cured to a higher percentage of patients who can be cured. So this is kind of the gold standard. I always talk to my students and other pharmacists and residents when I approach a patient in this day of age, when we treat myeloma, you have to look at all these general principles because they're all equally important. And actually a lot of what we propose in terms of clinical trials revolves around many of these concepts. So first, you focus on the patient. Not even age has become important. As you know, we can treat an 80-year-old very aggressively. So it becomes more the biology, the biology of the age and the frailty of the patients. You know, now we have several measures of frailty in myeloma. Specifically, the International Myeloma Working Group Frailty Scale has been validated and can actually be used to assess our patients upfront to determine the intensity of therapy that they can receive. And this is all coupled with comorbidities, like you heard before, whether or not the patient has a history of diabetes and can tolerate some of these heavily steroid type regimens, whether they have pre-existing cytopenias, which becomes actually a very, very interesting consideration, especially in the quad and penta-refractory stage of therapy, because it really is a limiting factor when we are treating these patients. But then apart from the patients and the prototype that we're treating, then we start looking at things like disease. While ISS and ISS staging doesn't seem to be really affecting how we treat patients, we look at things like, what is the rate of progression in this patient? Do they have extramedullary disease? We know now that we have a drug that's newly approved, melflufen, which actually has shown increased activity in EMD, or extramedullary disease. And then importantly, the genomic landscape has become kind of a very hot topic in myeloma. And not only just the genomic landscape, but being able to actually do single cell RNA sequencing to understand exactly the biology of the disease and who will benefit from which treatments. So cytogenetics is becoming increasingly important in terms of intensity of therapy, types of therapy they receive, but also how we can identify new targets in drug discovery. And then obviously, as important as the patient and the disease itself is, let's be honest, we have all these new therapies in the penta-refractory setting, the quadra-refractory setting. How do we choose? How do we choose selinexor-based regimen versus a belantamab regimen versus an isatuximab-based regimen? And all this, while we do look at efficacy and the risk of the patient, it also ends up being, can the patient drive to the clinic twice a week? Can they afford these oral medications? Kind of owing to our pharmacoeconomic discussion. Do they have baseline complications that are going to preclude receiving these therapies, administration route, depth and duration of response to treatment? So you really have to do a very thorough interrogation of the treatment history, but also of the ability of the patient to get these treatments, like we said. And then you start looking at, okay, should they get a triplet versus a quadruplet? And again, you'll ask 5 people and you'll get 5 different answers. So everybody kind of has their own style of treatment. There is evidence that we follow, but then there's still a lot of unknowns in myeloma. And so this is kind of the template I use as I try to treat these patients in our collaborative model clinic. So I'll kind of go through each class. And again, I know you've heard some of this already, so I won't bore you with the granular details since you've already received the template on how these drugs work and what to expect. But I'll try to give you, again, kind of a more real world approach of how I have seen these things happen in clinical practice and what we do. And then also how I incorporate my knowledge of the drug and the disease to ignite ideas for research. So selinexor, as you heard, came to the scene as a very novel agent type drug. It was studied in AML and other diseases preclinically. And in myeloma, it made sense. It targets the XPO1 exporter protein, and it affects tumor suppressor proteins, and then eventually affects expression of mRNA translation of the factor kappa B. It's a selective inhibitor. It's the first in class of these SINE drugs. And when it first came out to the market, the dosing that it was approved was twice a week, each week. And I think everyone who has experience with this drug now probably never does that. Now there's regimens where they use once a week dosing. And this is because of the toxicity profile of this drug. So it's oral, it's great because the patient doesn't necessarily have to come to the clinic multiple times a week. It can be given orally, but it comes with downfalls as well that you have to be able to figure out for the patient. So we at UIC came up with a treatment regimen where we actually still have the patient come in once a week. We give them IV antiemetics. We give them fosaprepitant and we give them pelonosetron because of its long half-life to cover them for the week. And we mostly have moved to a once weekly dosing. And then we usually will have them monitored every week for labs and symptoms. And then during the first week, we have them not only come day 1, but also day 3 to make sure that they don't experience hyponatremia, which can happen fairly quickly. So that's selinexor. It's FDA approved in combination with corticosteroids for patients who are at least refractory to 4 lines of therapy. The nice thing is it doesn't require any renal or hepatic dose adjustment. However, it has a plethora of side effects. And while it does have a plethora of side effects, you can achieve a balance to get some response, but avoid some of these toxicities. And a lot of these toxicities can actually be managed from a supportive care standpoint. So hematologic toxicity is something common we see. We've actually instituted a protocol where in patients who have baseline cytopenias, which is a majority of cases when you think about these patients coming into the relapse refractory setting, we try to get a thrombopoietin agonist covered by the insurance. And we try to give them either Nplate or Promacta to try to keep their platelet counts up, because that's usually the one value that limits them from getting this therapy on a timely schedule. We monitor for neutropenia and infection. We consider the use of G-CSF if needed. Nausea and vomiting, like I said, apart from just giving a 5-HT3 antagonist, we give patients neurokinin receptor antagonist as well. We also send them home with a PRN prescription with ondansetron, and we usually have a follow-up phone call from our specialty pharmacy to ask the patient how they're doing. So we've kind of developed a model for some of these orals in myeloma, not only from the physician standpoint, from the clinical pharmacist standpoint, but we have an on-site specialty pharmacy that has standard follow-up phone calls to follow up to see if the patient has any side effects. And then hyponatremia is something very common that we see as well. It can happen at a median onset of 8 days, but like I said, it can happen as early as a couple of days. So we monitor serum sodium levels at baseline and then throughout treatment, and we treat the hyponatremia if needed. So not only is it FDA combined with dexamethasone, it also has been approved to be combined with bortezomib and steroids after failing at least one previous therapy. And so you can see here that it becomes a very complicated schedule. You saw the ixazomib schedule before. Many of these therapies, because we're starting to combine orals with IV or sub-Q, with once a week versus twice a week. I mean, I think we can all admit that it becomes complicated even for us to follow, let alone a patient who doesn't have many resources to help them at home. We always make sure, like I said, to have supportive care prophylactically, but also we have plans as a management style. So we will usually have nutrition consulted. We have a dietitian in our clinic that gets consulted as needed, especially if we start to see weight loss after selinexor, which is something that we have seen in our patients. So we monitor weight at each visit, and if we see significant weight loss, it's actually in the prescribing information to adjust the dose based on that. So these are I won't go through all of this, but this is kind of the select adverse effects that we draw specific attention to because they are very common. And like I said, there are protocols, very structured protocols on how to approach the dose for selinexor. So it almost becomes, you have to become a little bit creative. You know, what is the right dose for the patient? Make sure they're not on any potent cytochrome 3450, cytochrome 384 inhibitors or inducers, and just keeping close monitoring with the patient is really important. And this is, again, is out of the prescribing information. It tells us what level of grade of toxicity warrants some kind of intervention and lowering the dose by one dose level, and then instituting some kind of supportive care for these patients when they experience this toxicity. I will say from personal experience, selinexor is low on my list to give. Again, it takes one patient to have a horrible experience for you as a provider to be like, I would not want to give the patient this therapy right now. And I've had some patients do really well. So you really do have to pay attention to the detail of the prototype, the patient, the characteristics of the patient, but also how well you think they'll tolerate the treatment from a myelosuppression standpoint and from a toxicity standpoint. So briefly, I'll go through venetoclax. And again, like our last speaker also, I won't spend too much time, but I like this drug now because we are starting to consider it. You know, the Bellini trial was put on hold temporarily because there was increased observation of death in patients on the venetoclax arm. So since then, we've had mature data being presented at several meetings. And I think we have a specific subset of patients we know who would benefit from venetoclax. Specifically, if it's a patient who you know has translocation 1114 and has failed at least 2 prior lines of therapy, it can be combined with dexamethasone or bortezomib. And like I said, it does have some efficacy, very comparable to a lot of these agents in the 3rd, 4th line of therapy. Now, it's important to recognize, however, you have to make sure the patient is getting PJP prophylaxis, they're getting an antiviral, and they're getting prophylactic antibiotics, because they did see increased risk of infection in patients who are getting venetoclax. Diarrhea can also happen, nausea, cytopenias, and then obviously, just like in the AML setting and the CLL setting, monitoring for important drug-drug interactions is very important. Otherwise, venetoclax from a broad spectrum, you know, we see the risk of infection mostly in the lymphoid diseases. We saw, you know, in CLL, we see a higher risk of PJP. There's several different types of infections that have been reported. And we're seeing this in myeloma as well, because again, these are very immunosuppressive disease states. So it's important to recognize who can get this drug, but also it's important to recognize that you have to institute the right prophylaxis agents to make sure the patient doesn't have any infections unnecessarily. Melflufen is the next agent. Again, you heard a little bit about it. I became very interested in this drug because I'm very interested in melphalan, which you're probably like, why would you be interested in melphalan? It's old school conventional medication. However, we know melphalan has extremely high efficacy in myeloma. It's probably one of the single most active agents in myeloma. So melflufen came to the scene, and actually the company claims that it's kind of a hyperactive melphalan because you get this high alkylator payload intracellularly, because it's a kind of a first-in-class peptide drug conjugate. So it's according to some of the pharmacokinetic studies and the pharmacodynamic studies, you get similar exposure in terms of melphalan exposure, because that's the active drug. But the point is that you get this high intracellular payload that causes increased DNA damage. And so melflufen, although I gotta say, in the past month or so, it's getting a lot of bad press. They've actually had to put a hold on all clinical trials because they, again, very similar to venetoclax, there was increased risk of death in patients. And so we've been told that there's updated results at IMW, which is happening right now. But I think they'll be able to kind of overcome this and be able to proceed with clinical trials. But it was used in combination with dexamethasone. It's an IV therapy in patients with relapsed refractory myeloma after at least 4 lines of therapy. It's intravenous, 40 milligrams once every month as a 30-minute infusion. It's combined with standard dose dexamethasone, and you can consider giving a 5-HT3 antagonist prophylactically. One of the nice things about this medication is because it's a you know, at the end of the day, it's an alkylating agent. The most concerning side effects is myelosuppression. And so you can actually, we've developed protocols where we have the patient take filgrastim on the week prior to starting the next dose 3 times a week, and we've been able to successfully keep people on schedule. We've also given patients, again, very similar thrombopoietin agonists to try to sustain their blood counts so that they receive treatment on time, which I think is important in myeloma. I think not a lot of people have looked at the role of relative dose intensity of these therapies and whether staying on therapy on time and at the right dose matters. And we're actually doing a study looking at this, but I think it is important, and it will prove to be important, especially as we get into these therapies that are a bit more complicated and compliance becomes an issue. So like I said, thrombocytopenia, neutropenia, monitoring blood counts is very important. And then there's dose reductions that are recommended. I am specifically interested in this drug, and actually we are talking to the company to open a trial studying melflufen in patients who meet criteria for frailty, and kind of monitoring frailty in these patients and how they tolerate therapy. So it does offer some advantages that other drugs like selinexor don't. And again, that's just focusing on a little bit of the toxicity, so I won't go into detail since you've heard a little bit about that. So now I want to focus on some of these really innovative treatments in myeloma that have kind of, you know, we started with some of these antibody drug conjugates, CAR T cells, bispecific antibodies. We've seen them in Hodgkin's, we've seen them in ALL, we've seen them in lymphoma, and now they're exploding in myeloma. And these are all agents that specifically target BCMA. And so we have our antibody drug conjugates, which basically deliver cytotoxic payloads released into the cell and cause myeloma cell death. We have the greatest power of all right now is CAR T cells. It's the hot topic everywhere. And then finally, we have some bispecific antibodies that are, you know, probably coming to the market soon, specifically in myeloma. So I think it's important to stop and talk about BCMA since all these drugs work on BCMA. So BCMA is very important. It's an antigen that's expressed specifically on plasma and myeloma cells. And there's much higher expression actually on myeloma cells when compared to normal plasma cells. And the nice thing is it's not expressed on other tissues. So in plasma cells, BCMA supports survival of long-lived plasma cells, antibody production, class switch of immunoglobulins are very important. But at the same time, it promotes myeloma cell growth, chemotherapy resistance. It actually causes a very immunosuppressive bone marrow microenvironment, which favors resistance to a lot of these drugs. And we know there's actually there's data to show that the expression of BCMA changes over time as you progress from some of these pre-malignant MGUS stages to more advanced plasma cell leukemia. So we know that it plays a very important role in the pathogenesis and progression of myeloma. And we also know that increased soluble BCMA levels have been associated with inferior outcomes in myeloma. And this is becoming a hot topic as a mechanism of resistance to CAR T therapy. So you heard in the previous discussion that, you know, CAR T came onto the scene. We had seen all the results in ALL. We had seen all the results in diffuse large B-cell lymphoma, and it was very promising. And we saw those results in myeloma. But I think now as this data comes to fruition, we're seeing real world data being reported. We're seeing, you know, it just got FDA approved recently, but we're seeing results, updated results of these trials. We're seeing that it's not foolproof. It's not 100%, of course. Now, we know that in patients who are pentarefractory, they're going into CR, which is amazing. But then there seems to be a plateau occurring, and we are starting to better understand why that is happening. And we'll talk about that a little bit. But these are some of the selected BCMA targeted therapies that are in the pipeline preclinically and in clinical trials, and then some of the ones that have been FDA approved now recently in the fall, I think it was April or March, where we had the first CAR T product approved for myeloma. So we'll first talk about belantamab. And again, I know you heard a little bit about it, so I'll try to keep it short and quick. But belantamab, you know, similar to like brentuximab in Hodgkin's disease. It's a humanized afucosylated IgG1 BCMA targeted antibody drug conjugate that neutralizes soluble BCMA. So you can see here, it has the anti-BCMA antigen binding sites, the monoclonal antibody that targets the tumor specific antigen. And then the cytotoxic component is this MMAF. So you've probably seen some of these moieties from the ADCs. It's either MMAE, MMAF, but this is basically the potent cytotoxic agent that when intracellular causes apoptosis, causes enhanced ADCC, and owes the efficacy to this drug. The linker allows the drug to be stable in circulation, and then the afucosylation enhances the antibody drug mediated complement cytotoxicity of the drug. So it's the BELLA trials, we call them the BELLA trials, it's also called BELLA. It was approved for patients with relapsed refractory myeloma after at least 4 lines of therapy that included either an anti-CD38 monoclonal antibody, a PI, and an IMiD. And its current dosing is 2.5 milligrams per kilogram intravenously every 3 weeks as a 30-minute infusion. It's only available through a REMS program, and I will say it is a bit painful to go through it. However, the company has come up with actually a very excellent way of navigating the REMS program and making sure that you dot your I's and you cross your T's, because you don't want to give this drug to a patient who has not had a formal periodic ophthalmology consult and assessment. So since we've used this drug, we actually have close contact with our ophthalmologist at UIC. And he basically, I mean, sometimes it takes months to see ophthalmology. This guy drops everything and sees the patient every month before the next dose is due. And I will, to echo Dr. Islam, I mean, it's true. The majority of patients will develop some level of keratopathy, and it's brutal. It's brutal actually to manage, and unfortunately, even for, based on the PI, even for grade 2 keratopathy, you have to hold the dose until it improves, and improvement takes a long time. So it really is the limiting aspect of this drug, because it does have, I think, a lot of great potential and efficacy based on the DREAM study. So DREAM 2 was the single agent with steroids. There's also a DREAM 6 where it was used in combination with bortezomib. Again, you know, a lot of the data that we see with these medications in this setting is comparable. And really, this is kind of the most common and probably most alerting side effect. So as we heard before, you know, interrogating the patient, making sure you get a good history. If they're diabetic, if they're non-compliant, they won't make it to their appointments. It may be not worth their while to receive a drug like this. So we have formal consults. We go through REMS. We make sure the patient is clear to go through the REMS program. Eye exams, including a visual acuity and a slit lamp exam, have to be done at baseline prior to each dose, and then anytime the patient complains of worsening clinical symptoms. All patients get a preservative-free lubricant eye drop throughout treatment at least 4 times a day. And although the trials used dexamethasone prophylactically, it's not actually recommended in the PI, so it was not necessary. And then obviously you have to monitor the patient because it is a monoclonal antibody. You have to monitor for infusion reactions, and then myelosuppression as well can happen. So this is kind of an overview of the corneal toxicity that can happen. You have to counsel the patient to make sure that they use this preservative-free lubricant eye drop. I've had patients come back to me saying, oh, I thought I was only supposed to use it when I needed to use it. And so we held therapy, we counseled them again, we went through it, and it happened to be that this patient didn't speak English, and I think there was some misunderstanding. So it really is important for repetitive education. But as you can see here, at the sign of grade 2 corneal toxicity, you have to hold until it improves to grade 1, and you really need a specialized ophthalmologist who can really appreciate the fine changes in visual acuity. We actually, our ophthalmologist has long been in management of ocular GVHD, and so he has some research now actually in this area to use immunoglobulin eye drops for patients as a prophylaxis to prevent corneal toxicity. He's studying it right now. Nothing is in fruition or matured yet, but it's interesting concept because the idea is that it blocks the FC receptor and it blocks the binding of the drug to certain the corneal cells in the eye. I don't understand the eye. The eye is super complex, but it sounds really interesting to me. We'll see. I mean, there could be therapies, supportive care therapies that may emerge to help us kind of get around this toxicity. Now, in terms of what's on the horizon, what's already going to come to us, you have your bispecific antibodies and you have your CAR-T. So there's some differences, obviously, between these two therapies. Now, bispecifics are off the shelf. We know we have allo products coming out for CAR-T that will eventually be off the shelf as well. But CAR-T therapy itself, currently, with the products that are available, Abecma, which is through BMS, is the FDA approved one. So you have to go through this complex process of manufacturing, collection of the patient, manufacturing, expanding of the cells, and then lymphodepletion and administration of the CAR-T, and then monitoring after that. So it's a very involved process. And there's a lymphodepletion chemotherapy that is necessary. It's a single dose compared to repetitive dosing of the bispecific antibodies. And there's definitely greater risk of CRS in these patients. And in fact, in myeloma, what we're seeing is that you can have a delayed CRS, and this could be due to the kinetics of the expansion of the product. So, oh, sorry, next slide. Oh, it's not letting me go here for some reason. Sorry about that. Oh, there we go. Sorry about that. So, like I said, the FDA-approved agents, and again, I always don't like to say them because I know I don't say them right, but I call it Abecma. But the BCMA-directed genetically modified autologous CAR-T therapy that's approved in myeloma. You know, they just presented some updated results actually at IMW. But you may be very familiar with CAR-T, but you're basically engaging the T cells to specifically targeting BCMA positive cells. And you're collecting these T cells and you're manufacturing them and you're expanding them. So they actually studied kind of a dosing cohort of this product, and the higher the dose, the better the outcomes. Now, having said that, what we're seeing is that about 60% of patients needed bridging therapy from the time that the cells were being manufactured and expanded to the time that they actually started lymphodepletion. And what we're also learning is that the types of therapy that patients receive prior to CAR-T can in fact affect the functionality of the T cells that are being collected. And so all this research is being invested in how do we dual target BCMA? How do we put on an on-off switch so that they don't get cytokine storms? How do we move this therapy a little bit more upfront so that you don't get this T cell exhaustion? Can we give therapies that could actually improve some of these T cell exhaustion markers like Pembro? In fact, some data just came out on the use of Pembro with the CAR-T products in lymphoma. And I think it'll come out probably in myeloma too, is how do we actually improve the bone marrow immunosuppressive microenvironment to sustain responses and to improve persistence after CAR-T. So CAR-T comes with a whole slew of side effects, which again, I think we now have so much experience that we can at least try to prevent and manage them. But all patients have to get lymphodepletion chemotherapy. This is a standard flu-cy regimen that's given over 3 days. And then the product itself, on the day of the product, the patient has to be pre-medicated with Tylenol and H1 antihistamine. But obviously we try to avoid systemic steroids, although there is some data now that shows that even if you do give steroids, it doesn't seem to impact outcomes in myeloma. And again, these are some of your frequent side effects. Cytokine release syndrome is really the big side effect, and this happens when you get this T cell expansion. Very similar to like what you see in haploidentical transplant. You get this surge of T cell expansion. And so with that comes fevers, hypotension, oxygen desaturation. ASTCT has guidelines on how to grade CRS and then how to manage CRS. And so we follow those guidelines. And some of these are obviously very objective, but the other toxicities can be quite subtle, and you have to have a neurology consult on board from day one. So the phenomenon that we see actually is a type of neurotoxicity that can happen after CAR-T called ICANS. And while we know what happens in other diseases, we're still trying to learn what happens in myeloma, because we can see ICANS, but then there's a delayed neurotoxicity actually that happens later after CAR-T in myeloma. So it's, again, at UIC, we still admit these patients to the hospital in the bone marrow unit. We monitor them for at least 7 days after the CAR-T infusion. And we provide standard supportive care, IVIG infusions if needed. And we have neurology on board to identify any signs or symptoms of neurotoxicity. And obviously for CRS, we institute steroids or tocilizumab, which is an IL-6 antagonist when needed. Anakinra is another therapy that has been used for CRS, but also for the treatment of ICANS. So it really is important as an institution. We, as a standard, always have 4 doses on hand, 4 doses of tocilizumab on hand whenever we have a CAR-T patient admitted. So just recently, it was a big thing. Tocilizumab was on shortage, and it was a huge thing. What do we do? And so now it seems to have been restored, but we had to actually think about some other options like cetuximab, which is another IL-6 antagonist, the use of anakinra. But luckily, we've been able to procure tocilizumab for the patients that are upcoming. But it is definitely a pharmacist consideration. Our physicians came up to me and said, we can't do CAR-T for tocilizumab, so what do we do? And so you have to come up with a stepwise approach on lines of therapy, what we would do. And we actually decided it's just such a high resource treatment that it's not worth doing it if you don't have tocilizumab on hand, because these other therapies are still investigative, especially cetuximab. There's one blood advances review on anakinra. And again, it's very limited data, so we just don't know. The gold standard is tocilizumab. ICANS is the immune effector cell associated neurotoxicity that I talked about. All patients should get prophylaxis with seizure and anti-seizure medication. We give levetiracetam prophylactically, and it begins during lymphodepletion and continues for at least 30 days, and then we start to taper it down. But again, we monitor for a lot of these neurologic signs and symptoms, and then we treat them as needed. And just due to the sake of time, I won't go in depth with the clinical data, but I do want you to realize that with CAR-T and myeloma, it's great. We've seen really good responses. Almost all patients respond. They have at least a partial response. Actually, majority of patients get CR. And we had several patients who are in penta or quadri-refractory disease who are getting MRD negativity. Unfortunately, as we heard before, there is a plateau in the curve, and we are starting to recognize some of these mechanisms of resistance and how we're trying to kind of better this therapy for patients. And like I said, you'll see some of these therapies move up front, because I think that's where we will see the biggest efficacy and the biggest benefit from these therapies. So this kind of sums up some of the products that are approved versus in line. Cilta-cel is ready to go from the CAR-T2 trials that are probably it'd be the next one to be FDA approved, and that's Janssen. So again, very promising therapies. Now, I can stop here. I actually had wanted to talk a little bit about our clinical trial that focuses on an innovative way of giving melphalan, but because of time, I will stop, and I can offer these slides to you. Obviously, you can read a little bit on your own, but we are at UIC, we have a programmatic interest in PK and optimizing PK of conditioning therapy. And so we published on our preliminary experience with actually doing real-time pharmacokinetics of melphalan during preconditioning for transplant, and being able to change the second dose based on an individual's exposure from the first dose. So we actually have a phase 1 AUC escalation cohort study that we are in the middle of doing right now. It's very exciting, and we're reproducing results within 24 hours to change the second dose. Very similar to busulfan, if any of you have experience with therapeutic drug monitoring with busulfan. And this is kind of a joint project between UIC and Emory. And we hope that in the next couple of years, we can report some of our findings. So with that, I will stop. And I'm sorry if I went over time, but I'm happy to take any questions from anyone.
Thank you
Thank you.
so much. Thank you so much, Dr. Karen, for this comprehensive presentation. Actually, we have a couple of questions. First question is from Dr. Ali Najidi. He's asking, does pharmacogenomics can help in decreasing therapy relapse in multiple myeloma patients?
Yeah, that's a really good question. So, we know pharmacogenomics has made it into therapies like 6-mercaptopurine, thioguanine, methotrexate, even with dihydrofolate reductase with pediatrics. Unfortunately, has not made it into myeloma yet. Now, I would go one step further and say pharmacogenomics is great in that it can tell us germline mutations, right? At the start of therapy, does this patient have a certain mutation or a certain SNP? For example, they're a low expressor and cannot metabolize CYP substrates very well. I would go the extra step and say, what is more important is actually not necessarily genotyping, but phenotyping, cytochrome P450 phenotyping. And that's because we know that it's not just the mutations that happen, but what can actually affect the function of the protein. So we know myeloma is a very cytokine heavy disease state, and cytokines can inhibit cytochrome P453A4. We know age-related changes in CYP happen. So there's many things that can actually impact CYP-related activity. So we have it's interesting you bring this up, but we have a study that was actually funded by HOPA, which is the Hematology Oncology Pharmacy Association. And we were funded a year ago to CYP phenotype patients undergoing bortezomib. And we are phenotyping them by using probe drugs for CYP3A4 and CYP2C19, which are the two pathways that in majority of cases metabolize this drug. And we'll be measuring the clearance of these probe drugs, the clearance of bortezomib, and we'll be correlating it with outcomes of therapy. And then we're also going to be looking at cytokine levels throughout treatment and how that impacts CYP activity. We'll also genotype these patients to see what type of mutations they have. And so it's an important question. Unfortunately, I don't think it's made it to prime time. I think, unfortunately, in a world where we expect these large scale kind of clinical trials, I think an emphasis on improving the way we give drugs has not been a heavy emphasis. And, you talk to these companies and it's just not priority on their list right now, right? So I think it's important for us as pharmacists to kind of begin these investigator-initiated trials and do it on our own and provide some unique, innovative research that helps support the use of these things in clinical practice.
Yes.
That's
Great. The second question is by Dr. Hiyam. She's asking, based on your clinical practice, what do you think is the best first-line regimen that we should give to our patients to prevent relapse for newly diagnosed patients?
Yeah, that's a good question. So first-line therapy, when somebody asks me what first-line therapy is, it's a bundled package. So to me, the optimal first-line treatment, and again, this is whether you're transplant eligible and not eligible. If a patient does not have significant frailty or comorbidities, I prefer a 3 or 4 drug regimen. Now, my first line would be a 4-drug regimen, but I don't know how it is at other institutions. I work at UIC, which is it's a minority-based. It treats a minority-based population, and so it's important to recognize that because unfortunately, many of our patients can't come to clinic very often, or they can't afford transportation, or they don't want to get sub-Q therapy or IV therapy. So we always have this discussion. We actually tell patients, look, we don't think that not getting a 4-drug regimen will affect your your overall initial response to treatment. So I will say in the majority of cases, I actually give 3-drug regimen, but we are starting to identify patients who can benefit from 4-drug regimen. But that's not where it stops. It's really important you do not delay treatment to transplant. We know that that's associated with inferior outcomes. So making sure that you mobilize the patient up front you get them their treatment, you provide them supportive care. Bisphosphonate is crucial for therapy as well. They get their first line treatment, they go to autologous transplant right away. And then again, it doesn't stop there. And then identifying what the best maintenance therapy is. So most patients, lenalidomide single agent is appropriate, but then there are high risk patients. So patients, for example, who have high risk disease from the beginning, they're PEP positive disease, extramedullary disease, high risk cytogenetics. These are the patients that we actually give continuous triplet therapy. We continue their initial treatment throughout the maintenance phase. And again, because this is a high risk patient population, that's the biology of the disease. So that's kind of my approach. Now, I do think it's going to change probably, sooner than later. I think the treatment paradigm in myeloma is changing so much. I think you have to realize right now, the name of the game is, who do I partner which drug with? Now, the game changer will be, how do I address high risk therapy? How do I address older, more frail patients? How do I treat them optimally without killing them with side effects? How do I treat high-risk patients who will probably rapidly progress within 1 year of transplant? Those are really the questions that I think seem to be still unanswered, but are very important.
Great, thank you so much. I have a final question. It's actually from me. During the COVID-19 pandemic, how did UIC change the management of patients with multiple myeloma?
Yeah, that's a very good question. It's kind of the hot question these days, right? I mean, I think we've all in some way or another been affected as providers and patients and caregivers from COVID. So there's some things, unfortunately, that you can't get around, right? For immunomodulators, you have to have them come in for labs. They have to be seen. And so what we've done is we transitioned many of our patients to virtual consultations, and they've still had to come in for labs, but that lessens your time in clinic. If you just come in for a lab check, it's much easier than having to wait in the waiting room that has 50 other people. And sometimes wait times can be 30 minutes, hours. So we have replaced many of those visits that we think are okay to replace from a clinical standpoint virtually. So it's a lot of actually our very stable maintenance patients. We've been able to do that. In terms of treatment, I will say we actually did a survey. We did a survey of our patients to see if they believed that their care changed. And we saw that actually most patients did not get delays in their therapy. If it was infusional therapy or sub-Q IV therapy, they did not observe any delays in therapy. They did not have delays in getting tests that they needed to get tested. Now, it does become cumbersome. You have to get COVID tested before you get a PET scan. You have to get COVID tested before you go to the hospital to get your autologous transplant. But luckily, I think I think the nice thing is in myeloma, there were some patients, especially when there was a spike. I think when you talk about AML patients and delaying allogeneic transplant, most people would say no way. I think delaying although I just said delaying transplant is worse, I think we have kind of a wiggle room, right, in myeloma, where we can continue first-line therapy a little bit longer and delay time to transplant if needed. We have to make that decision in some people, but most people actually, we did not. I think probably the most common problem or side effect of COVID that we saw was just that we had to do a lot of virtual visits. And I have to say that was challenging in itself. We have people who don't have working phones or who don't have Wi-Fi or don't have a computer. I mean, real problems. And so, we had to call patients on the phone and talk to them without actually seeing them. So I think that's actually gotten a lot better. We've been able to get around it. It's definitely probably affected other disease states more so. Again, because our therapies, you need to sign off in REMS for them to get an immunomodulator. But I think other therapies, they probably have seen more of the effects than others.
Great. Thank you so much. Thank you so much, Dr. Karen, for your presentation and answering our questions.
You're welcome. Thank you.
Thank you. Now we will be seeing the ACPE information for our US licensed pharmacist. So the attendance code for this session is PMPX. So PMPX. Claiming instructions will be shared via email within 1 week. And now it comes to the end of our meeting. I want to thank all our speakers for their presentations. and their answers and their comprehensive, fruitful discussion. And now it comes to the funniest educational part of our meeting, the Kahoot, by our amazing organizing member, Dr. Ahmed Abdeldaim.
Assalamu alaikum wa rahmatullah, everybody. Thank you for joining us in another insightful session about multiple myeloma. And finally, for this great series, thanks to our great faculty for the insightful session. Actually, I'm not an oncology expert. However, I enjoyed every single minute. Thanks to Dr. Fatima for the great moderation, which added a non-replaceable touch to our, even Dr. Islam, if you think that Cristiano is famous, our Kahoot is very famous among IVPN community. So despite I'm not as famous as Cristiano Ronaldo, but I believe they like this session. So let's move to our Kahoot lesson. Ladies and gentlemen, we were talking today about multiple myeloma, a common disease among cancer patients, which gave me an idea to share with you. I believe as non-expert that simply multiple myeloma is an imbalance between among the normal states. This is the normal bone marrow. But when it comes to multiple myeloma, this is actually what happens. It's some sort of imbalance between plasma cells and its colleague cells. So how it relates to our today's Kahoot lesson, actually, and this is not fake, this is what happened yesterday. I received the consultation from one of our colleagues asking me, Ahmed, I would like to know whether should I get a pharmacy, a board specialty certification, should I get CPHQ or should I get actually professional degree in medical coding? Which one of them do you think can increase my employment opportunities? The coming slide is my own opinion, which I hope you would like it. Just think about an answer while I give my own opinion. Actually, I told her, dear colleagues, is some sort of similar to myeloma cause or myeloma patients. It's about establishing the balance. So it's not only about certification, it's not only about experience, it's not only about making connections, it's about maintaining balance between all of these issues in order to make sure to secure good employment opportunities. So just keep in mind, that's why actually in IVPN network, if you visit our site, you go to our listservs and you go to our oncology listserv, I assure you, through joining, you will be able to find the expertise to ask, you will be able to find the knowledge, and you will be able to nourish yourself with great experience about oncology, which ultimately can help you secure good employment opportunity. This is my disclosures as disclosure as a fair opportunity organization. These are my cumulative and engagement questions. Now in chat box, you will find the link to the Kahoot and the code. So simply just press the link or follow the instructions that I will give you in a minute in the next slide. So whether you access our Kahoot from Google Store, App Store, or desktop, make sure to press the link that I shared in the chat box. You will get this screen, then enter the PIN code that is sent in the chat box, enter your email with which you registered to today's activity, and ultimately enter a nickname and preferably your first and last name so that we can recognize you. Again, press the link in the chat box, then enter the PIN code that appears, enter the email address with which you register to our activity for us to reach to you, and finally enter a nickname, preferably your first and last names. Without further ado, let's move on to our beloved Blue Kahoot screen. And as usual, many enthusiastic participants. I miss you guys. It has been 2 IVPNRs without seeing you. So it's good to have this nice reunion at the finale of oncology series. Again, the join procedure is very simple. Just press the link in the chat box and enter the code that appears in the screen or the one posted in our chat box. The code is 1493-637. make sure to join our oncology listserv after this activity. And for those who are asking about personalized medicine, thankfully with our leader, Dr. Muhammad Nagi, we are conducting a regular series to increase awareness about personalized medicine. Make sure to visit our website and join our activity. Follow us on our social media. For those who join us for the first time, it's a game about accuracy, about speed, about engagement, about cumulative knowledge. It's life experience. Do not miss the opportunity to join us. For those who win with us, they can access our Hall of Fame, Kahoot Hall of Fame, on our website. Are we hitting 70 today? It's priceless opportunity to be engaged and known to pharmacy community in the region and beyond. Special hint for today's activity, the answers are very easy. I assure you, if you focus with the answers, you will be able to get 100% today. Are we hitting 70? For the sake of time, we'll start in 2 minutes. The PIN code again is 1493637. If you get disconnected during our activity, just write down this code, enter it again, and you will get admitted again to the game. Kindly rest assured that it's never decided until the last moment. For Kahoot experienced people, they know until the last moment there is always changing plans. Who is gonna join us today? 30 seconds to go. For the last time, the code is 1493637. If you get disconnected, just join us again through this code. So starting our game in 5, 4, 3, 2, 1. Let the fun begins. And starting with Dr. Islam. So all is false about stem cell transplant for multiple myeloma patients, except, remember, focus with the answers. The cutoff age is 65 to 70. When it is suggested to you, make sure to give this advice. And Lama in the top, and Manal Al-Alabi, our personalized medicine advocate, is after you, Lama, so take care. Anti-BCMA CAR-T is associated with response plateaus after 1 year. Is it right or wrong? Just say it. Mentioned 1 minute ago by Dr. Karim. It's true, and my pronunciation of BCMA is true also according to Dr. Khalil. So let's see who made it. Batta, welcome Batta. I think she is making great job. Best option for multiple myeloma treatment is the, which one? By our National Guard expert, Dr. Hana Al-Abdel Karim. Definitely cost-effective option, which is lowest price with similar efficacy. And here we have Batta maintaining her progress. But Yakin is after you, but I can recognize her. Not routinely used in multiple myeloma treatment. It's Tarabin. I hope you changed your mind, Dr. Islam, about today's activity. And Nizar coming to the top, another champion from the previous activities, not associated with Selexinor treatment. Thanks, Dr. Karim, for sharing with us very nice, insightful information about side effects of medication. Make sure to follow the study that she will share later. Fatima, I'm not quite sure if she's our Fatima or not, but you are making it hot, Fatima. What is type of innovative managed entry agreement into your formulary? Last time, Daniela Abilkhair told me, please keep all of the above always right. But it is never the case. It's actually outcome-based agreement, some sort of innovative pharmacoeconomic agreement with companies when it comes to chemotherapy. Great job, Dr. Fatima, but Yaqeen is after you. Great job, Yaqeen. Will you make change at the last moment? Pharmacists can help with personalized cancer treatment through from the insightful presentation by Dr. Daniel Zlatan, our recent clinical research activity. Definitely, appropriateness review or identifying synergistic antagonistic drug combinations, you can utilize it perfectly. Great insights from our great audience. Fulil, Riham, Ghada, totally 5 new names. Will you be able to maintain your excellence? Let's see at the last question, IVPN oncology lead is, should be 100% right answer, guys. Definitely, Dr. Fatima Ismail, almost 100%. Dear colleagues, I learn a lot from Dr. Fatima, not only in oncology, but also in her leadership and amazing management skills. Make sure to join her listserv to learn more. Let's see if there are change of points at the end. Who came in third place? Ghada, great job, Ghada. She maintained her position. Maya in the second place. Who made it to the top? Is it Fatima or somebody else? Well, great job, everybody, to maintain your excellence in such tough program. It's great job, Reham and Ashu coming in fourth and fifth place. We'll contact you, inshallah, very soon for your prizes. Thank you for joining another insightful session today. Moving the floor to Dr. Ahmed Awaini for the closing remarks. Dr. Ahmed, the floor is yours.
Thank you so much, dear brother Ahmed, for your outstanding Kahoot game experience as usual for our respected audience. Congratulations to our top 3 winners and every participant who enjoyed this game. With this, we come to the end of tonight's IVPN-AR, an outstanding event with invaluable lessons shared from our marvelous speakers, Dr. Abdul Karim, Dr. Al-Qunaisi, and Dr. Suwais, moderated by perfectly Dr. Fatima Ismail. Thank you, dear esteemed audience, for your active presence with us, and we hope that this IVPN-AR was of value to you. Thank you, Jansen, again for your support to this educational event, and to all IVPN respected partners. Special thanks to our IVPN big family of 70 leaders and ambassadors who are the cornerstone of this IVPN exponential growth. And please block your calendar for September 15th, which is this Wednesday, for our upcoming IVPN-AR on allergy and anaphylactic reactions. And we wish you a good rest of the day, everyone. And please don't forget to fill out the survey that just appeared now on your screen. We grow by your feedback to serve you better. Thank you and goodbye.